Before we start, I'd like to invite Dr. Vici to be on the panel. Dr. Azad will join us shortly. So on behalf of the SAO and the Indian ROP Society, I'd like to welcome all of you on this South Asian Ophthalmology Symposium on Retinopathy of Prematurity and newer developments. We have a string of specialists coming from different countries. We have Dr. Domenico Lepore from Italy, and we have Dr. Vici Wu from Taiwan. It'll be my privilege to start this off. नहीं slides ये पहला slide नहीं है. Okay, so very good morning again, and welcome to the SAO Symposium on Retinopathy of Prematurity. I have no financial disclosures and no conflict of interest. So I'm talking about imaging and newer imaging techniques in ROP, and I think this is so well elaborated in the new ICROP classification, where we started looking at vascular segmentation and and deeper ways of looking at the vessel profile. Let's take, for example, aggressive ROP, where one of the reasons we realized that this disease is so different from aggressive posterior ROP was, let's say, angiography, where we were looking at loops of capillary non-perfusion happening even anteriorly. And then the newer things in the ICROP3 classification, like how to assess regression and reactivation, are again a feature of how we were able to better define these images as we are looking at ROP. Reactivation, for example, can be a vascular reactivation or a ridge reactivation, and even the location of the reactivation has been defined purely based on what's happening on an image. Plus disease, I think all of us have struggled with it for decades now, and the fact that two or more experts may not even agree, and this has been very elaborated in several studies, and therefore imaging again has come to our help. The P-score has recently been released, and now I think we have a very objective score where we can put this up in our clinics, and from P1 to P9, it's a great way of two ROP experts communicating, especially when referrals happen. Let's talk a few about the newer imaging devices. So in our own program, in the KidROP program, we have a telemedicine program where we started to use the RedCam shuttle. It's wonderful. It gives us great images, but the program was not scalable because of the cost of the camera. So this was an Indian camera that was invented, and we have subsequently, I believe it has an FDA and a CA approval, and now has installations everywhere. The newer version of the Forest Neo has the angiography on it as well, and I think in this era of anti-VEGF and anti-VEGF therapy, angiography plays a very important role. There are also even lower, more affordable camera devices where you put in just a smartphone, what they call a smartphone assisted camera, where you put in a regular 20 diopter lens, or a 28 if you will, and connect it with an app that the developers have created. And yes, it's not as wide field and it doesn't have the ecosystem of a telemedicine program, but certainly very good for photo documentation. So may not be telemedicine, but great for photo documentation. Yes, so angiography, I'd like to spend a little time on looking at, oral angiography is being also performed in India. And here's an example. I think all of us see these cases now, aggressive ROP, which is what we call in India zone half, which is popularly actually should be called posterior zone 1. And it does very well, and that's when you begin to think that the vessels are fine and completely mature. But then when you do the angiogram, now this is a baby who's already almost 4.5 kilograms, and you have a large area, and again this is defined based on an image of 2 disc diameters or more of persistent avascular retina. And here you can just simply, based on the angiogram, look at 2 patterns. Firstly is the posterior leak, which you may not want to treat immediately. This tells you where the disease was and tells you that some activity is still there. But then you want to look at the edge leak. So if the edges are not leaking, then this is probably not a reactivation, and you can allow the vessels to grow further, of course subject to the fact that you might be lasering a baby eventually who's much heavier, and unless you have the option of sedation and general anesthesia, in India at least we prefer to laser them much earlier, depending on the comfort of the surgeon. So these babies undergo eventual laser, and combined therapy of anti-VEGF and laser is where the Indian ROP Society is also recommending its guidelines. OCT angiography is so popular in adult retina care, but somehow in pediatric, perhaps because of the fact that we don't have a handheld and a portable device, but we were able to use this in a flying baby position, and what we found was that all these years we believed that flat neovascularization of aggressive ROP was only on top of the retina, but because of the deeper ability to see on OCT angiography, we know now that this is a complex. It's not just NVE, but an NVC. And I think selectively targeting this NVE can reduce and can improve the outcome. We took this OCT angiography study a little ahead, and we started to look at children who are between age 5 and age 10 and who have abnormal avascular zones. And we saw that even if they had 6/9 or better vision, their deep capillary plexus somehow was preserved, but their superficial capillary plexus didn't do as well. And the on-fast OCT gives you another great picture on how we can determine, even though all of them are ophthalmoscopically normal and their visual acuities are normal, the fact that they have a fovea plana and persistence of the inner retinal layers is something to tell us that their fovealization is perhaps not normal, even though they clinically looked so. We are also using a contrast sensitivity on children, on babies undergoing ROP screening, and from there we're able to predict which baby will have poorer vision. A note on OCT. While we were looking at the OCT features of fovea and fovealization, we found that certain layers and certain activities in the fovealization process are either delayed or they're completely absent. And with that, some of these are the inner retinal layer fusion, the appearance of the external limiting membrane, and so on. They can actually predict which of these babies might have poorer vision going forward. The ultra-wide field is another great device. The only problem is it's currently not handheld, so you might have to put the baby on a flying baby position. This is a child who is almost now a teenager who was injected over obviously 12 years plus back and was said to be completely normal. But when you see that these are the long-term cicatricial changes which happen when you don't perhaps do combined therapy. So there's a persistent avascular retina, and sometimes they even leak, as you can see here. So this is active disease years after an anti-VEGF, and that's really important. I'm going to end with some prediction that we've been working in our institute. So we now have the ability to look at tear biomarkers. I was fairly surprised initially to understand that these babies who are undergoing ROP screening can even produce tears. So yes, you do produce them. It does get produced, and we started to look from 86 analytes to about 20. And now we have about 5 of them. Here's an example on how we are doing this. So these TR analysis happen at the first screening visit, and based on the biomarker profile in that TR, and some of those abbreviations are the ones I showed you in the previous slide, on how they are down or up-regulated, we are able to predict which of these babies will eventually get the disease, and we are hoping that we will be able to have a great prediction score, involving artificial intelligence and imaging on that. But right now we know that the interplay is not just VEGF and angiogenin, but also inflammatory molecules, as this paper shows, and there are certain molecules that get up and some that get down regulated, and which can help us predict whether these babies will progress in their ROP status. And continuing on our tear work was our vitamin D assays in the tears, and again they have a very strange relationship with the progression or regression of ROP based on whether you're seeing them at an early stage of ROP where they have a positive correlation and a negative correlation between vitamin D and VEGF at a later stage. And I think artificial intelligence is here to stay. We started working on this over a decade ago, and we now have the ability, we've created algorithms in India where these images are now being used in our setup offline we have a grant from the government of India, and we are hoping to have a device agnostic algorithm, which will eventually see technicians or non-physicians. As soon as they image, this algorithm will go in. Some of this work is here, where we're able to assess that, and this is an independent piece of work. The sensitivity is around 90 to 92%, which is good but not awesome. This is our most recent publication where we're using this to train people and see whether they can be aligned to the so-called gold standard where the ROP specialist is looking at. And I think the government here at least is very much keen on integrating artificial intelligence with cameras as the cost of the cameras goes down. To summarize, therefore, there have been a lot of affordable imaging advances in recent times from India for India and low middle income countries, and I think that's going to be the way going forward. But a machine is only as good as the use and its utility, and therefore artificial intelligence algorithms are here to stay, and they're going to be very soon already getting integrated into machine learning. And we hope that along with the TO biomarkers, imaging, demographics, risk factors, the AI will be able to give us a score where we're able to tell the mother when to come back with this baby and not necessarily weekly or fortnightly, only because we don't know how this disease will progress. So all in all, a very exciting time for ROP ahead. Thank you so much. Thank you to SAO, APAO, and AIOS for this opportunity.
Thank you, Anand, for your great lecture. Can we have a few questions? If you have a question, please stand up to the speaker. I have a few questions for you. So right now in the era of the portable OCT, Dr. Pete Campbell, he showed me in his system, Sion, yesterday, the fundus photo created by the portable OCT is amazing. So what's your prediction or what's your insight on the development of portable OCT versus the traditional color fundus imaging?
I think it's very exciting that I think the only thing that was holding us back was the availability of handheld wide field OCT, but with devices being made available, we have two startups in India that have both of them have booths here that are coming up with low cost wide field OCT. And we know that in the ICROP3, OCT has made its foray. I think its ability to predict the progression is definitely something that is very exciting and needs to be studied more. But as more data comes in, I think we'll be more confident in using it. I'm not sure as of now whether we can replace standard fundus imaging, but certainly it should be helping us to predict which babies will progress.
So do you think that's even more sensitive or not known yet?
Not sure yet, but excited about the possibilities.
Okay. Yeah, Alex?
Dr. Anna, thank you for your wonderful speech. So I would like to ask the tear collection of your study. So when you collect the tears, are the baby crying? And do you think there's a difference in the concentration of cytokines between the basal tears and the reflex tears?
So I don't think they have that kind of differentiation, because honestly, with the fluid that we're collecting on the Whatman filter paper may be just a cellular exudate, because at that point of time, they don't even have those tears. I mean, you see babies cry, but you don't see tears. I'm talking about anywhere between 32 weeks and 40 weeks. So I don't think we can make that distinction yet, which is why I was surprised that we're even getting such a big column of.
Okay, thank you.
Hi, Pete. Welcome to India.
Really nice talk. One of the issues you highlighted was the teenager who was treated with anti-VEGF.
Yes.
You know, and I think it's a really important issue. My friend and colleague Manny Chang is in Houston, where it was the epicenter of anti-VEGF use. You know, they were some of the first people, and here as well.
Yes.
But, those kids are now teenagers, and he's seeing a dramatic uptick in rhegmatogenous detachments in teenagers, even bilateral. So your point about combination therapy, there's two things. One is it's really important for us to think of combination therapy when we're treating babies. And the second is there's probably thousands of people at risk, children at risk out there right now who are going to look like that and develop problems.
I think that's
we need
such
to-
an important observation, and I think once that gets published, we definitely use that data to help us refine our own guidelines. I think thank you for sharing that. I think we need to move forward in the interest of time. Dr. Azad and Dr. Domenico are joining us shortly, so I'll invite co-chair Dr. Vici Wu, a great friend and a prolific ROP specialist.
Coagulation remain the standard treatment for ROP. It acts by destroying the peripheral vascular retina and reduce the VEGF production. And on the other hand, intravitreal anti-VEGF like bevacizumab, we work directly neutralize the VEGF in the vitreous. So because it did not destroy the retina, so it has better preservation of the retina. So each treatment has their advantage and drawbacks. One of the main drawbacks of the anti-VEGF use is that its association with potential neurodevelopmental impairments. Why? Because all of the intravitreal injection of anti-VEGF drug, they would lead to systemic circulation. In our prior study, we found out that if you inject bevacizumab or Prevacid, the systemic VEGF suppression was up to 12 weeks, almost 3 months. And because VEGF is such an important neurodevelopmental growth factor, so people would worry that in this vulnerable group of patients, whether their long-term neurodevelopmental outcome will be affected after such treatments. So we don't know their long-term outcome yet. So since 2016, we have been tracking our patient with prior treatment of the anti-VEGF, and we prospectively track those patients, and we use different neurodevelopmental tools to access their neurodevelopmental outcome appropriate to their age. So since 2016, 2019, 2021, and 2023, we have tracked their outcome, and we do not find significant differences in the individual treated with anti-VEGF versus their comparable control groups. Then recently, we did another study. We tracked the patients even further up to the age of 8. Why do we need to do this study? Because actually, our brain acquire 90% of brain volume after the age of 6. And some neurodevelopmental defect will not appear even before the age of 5. So if you do the neural assessment before 5, you could miss those problems. So we did a prospective study and enrolled 277 patients at our center. We have 4 groups of patients. Group 1 is full term, Group 2 is preterm, and Group 3 is ROP without treatment. Group 4 were ROP with laser or bevacizumab or both treatments. And the main outcome measure were the full-scale intelligence quotient, FIQ score, calculated by Wechsler intelligence scale for children, 4th edition, WISC-4. So WISC-4 is a cognitive assessment test appropriate for children aged 6 to 16 years old. It consists of 15 domains, evaluating verbal comprehension, perceptual reasoning, working memory, processing speed, and fluid reasoning. It has a mean score of 100 with standard deviation of 15, and in the prior research, it showed great consistency. So this is one of the examples of the test. You ask the children to read this number either forward or backward fashions and see how they perform. And here were the statistical analysis we did in these studies. Here were the results. So among the, compared to the full term and preterm without ROP, ROP group definitely have a lower GA, gestation age, and lower birth weight. And also compared to the full-term and the preterm without ROP, the ROP group have significantly worse vision. And here's the FIQ score, the full score and the percentile. Also, again, you compare to the full-term and preterm without ROP, the ROP group show lower score. Okay, so patient with ROP show significantly low FIQ score and percentile when compared to full-term and preterm without ROP. Then we just look at the ROP group, either without and with treatments. And, but then we look at their vision. We did not see significant differences in their visions. And then we look at their FIQ score. This is probably the most important slide. And basically, we didn't find significant differences in their full score and their percentile. So you could see that individual treated with laser or Avastin or combination has similar score. But you do see slightly lower score in the combined group. And then we did the linear regression model, and only two factors come out. One is low gestation age and lower vision were associated with lower score of the neurodevelopment. And in the percentile, similar findings were noted. Only GA, low GA, and poor vision were associated with the FIQ score. So basically, we did not find a normal neurodevelopmental outcome in patients with prior bevacizumab treatment compared to laser. But however, in the past, there are studies like this one performed by Dr. Maurice group from Canada. They do show that there were 3-4 increase in severe neurodevelopmental disability in patients receiving bevacizumab compared to treated with laser. However, there are a couple issues in this study. First is selection bias, because sicker infants were more in the bevacizumab group, and 11 infants in the mild disease was noted in the laser group. That means they do not meet the criteria of type 1 ROP and got treated. And there was imbalance in missing data as well. Bailey 3 assessment could not be performed for 9 infants in the laser group, but only 1 in the bevacizumab group. And for those babies, it's very likely they could have certain form of neurodevelopmental issues. Also, the loss to follow-up percentage was 28%. That could significantly skew the final outcomes. So recently, there are clinical trial data showing up, like Firefly Next, and as well as Rainbow Extension study. They don't see any significant neurodevelopmental issue in the eye treated with anti-VEGF. So the take-home message here is that we did not find significant differences in the FIQ score and percentile in the individual treated with bevacizumab compared to laser. And only lower gestation age and poor vision could correlate with a lower score. This paper was recently accepted in the Journal of Retina. If you are interested, you could reference this. And thanks so much for your attention. Thank you.
Thank you, Professor Vici. That's you've been doing a lot of work on the long-term outcomes of anti-VEGF, and you've demonstrated that in this recent publication as well. There has been a neurodevelopmental meta-analysis about 3 decades that came out of a few neonatologists in Europe, India, and Australia, where they looked at primarily the chances of cerebral palsy and autism in babies who were treated with anti-VEGF versus laser. And they found that although it was not statistically significant, there was a clinically higher significance of NDI. And then they found that those who had a second injection possibly had a higher chance of that. And those who had combined therapy, the chances of further worsening of NDI had reduced Do you have any thoughts on the second injection versus protection with laser combined with the first anti-VEGF?
Yeah, I think that's a great point. That's also a big concern for us. So that's the reason why in the past, I only performed the anti-VEGF injection once for over 99% of my patients. If they do not respond to the therapy, I switch to laser because you see that single injection results in suppression of systemic VEGF up to 3 months. So if you have a second injection, it could be 5 months or even longer, I don't know. So that's a big issue. But right now, because this treatment has been in practice for over a decade, so we have more and more long-term data coming out. So we should keep on surveying these data, and if there are signals showing that it could be potentially damaging the infant's development, we should let everyone know.
Thank you so much.
Thank you.
It's my pleasure and honor to invite Professor Domenico Lepore. He's going to be talking to us about understanding the pathophysiology of ROP with new insights and biomarkers. For everyone.
Thank you, Anand, for the invitation, and thank you to be here. It's a very early morning session, and see some people interested in ROP is always a pleasure. I'm going back to the science behind the use of the anti-VEGF in the ROP. So these are my disclosure as which I'm a consultant of Bayer for the Firefly study, and I'm involved in the board of the HICON instruments. The genesis of blood vessels is based on two principal mechanisms. One is the angiogenesis, and the other one is vasculogenesis. They are completely different. Vasculogenesis happens in the very early, around 20 weeks of gestational age, around the optic nerve, and it is not the one that we see during our clinical work. While we see the vasculogenesis with the angiogenesis, which is a different process. Basically, is a sprouting of the already existing vessels, and is driven by anti-VEGF. There are a lot of actors playing this game in the field, and we know for sure the VEGF, but also we have other factors like PDGF beta and TGF1 and angio1, which are involved in this differentiation and stabilization of the vessels. And angiotensin 2, which is the one that is involved in the sprouting of the already existing vessels. All these factors are potential target for therapy of retinopathy or prematurity. We use anti-VEGF because we know the VEGF since a lot of time, and we know a lot about the story of the VEGF, and we can consider them as a VEGF1 is a family of VEGF. The most important things you have to keep in your mind is there are VEGF with a low weight, which have no binding of capacity for heparin, which means they are soluble and they go spread around. And while other with a higher weight, they stay in the place, and they are responsible for creating a gradient inside the retina. And this is a schema that is very useful. This is done by Jane Rakesh in Boston. You see that if there is a correct concentration of the VEGF, you have a right development, and the phylopodia of the tip cells goes in the right direction. If there is a lot of soluble VEGF, we lose the polarization, and the vessels, the phylopodia comes to spread up to the retina. And if there is a ectopic VEGF, then there is a drastic loss of polarization. This means that vessels grows not only on the surface of the retina, but even in the vitreous. Given that, we have looked at the receptors of the VEGF1 family. There are two receptors. One is responsible for the chemotaxis and self-regulation of vessels. The second one, VEGF receptor 2, is responsible for mitogenesis, and we will see that this is another important target of therapy. So going to this fantastic schema, we see we can act as blocking the VEGF in the intercellular space, and this is done by the drugs that we already know, bevacizumab, and then also Lucentis, HILIA, and we can also start to have some blockade, possibility to blockade the VEGF photoreceptor 2, and we will see the work done by Amy Hartent. We are also another interesting option, which is blocking the tyrosine kinase cascade inside the cells. And finally, what is very promising is the use of RNA interference to block the protein through small fragment of RNA. The model of oxygen-induced retinopathy is highly representative for humans. This is very important. This model has been used by also other by oncologists and tissue engineering techniques to understand how it is feasible to let the vessels grow in a tissue. And the biphasic theory of ROP that comes from this basic science is an old one, is in place since the 50s by Arnold Patz, which was the first one to propose that ROP based on a biphasic theory. Well, the first one is vasoconstriction, where we have a loss of vessels due to relative hyperoxia. And you see here the actors that play this game are essentially the same, HF1, VEGF, EPO, and the omega-3 fat acid. And we tried to use the IGF-1 to restore the correct level of this factor, and the study that we have done failed in reducing the incidence of ROP. And the second one is the neovascularization, the one that we know very well from the clinic, and the inhibition of anti-VEGF, of the VEGF, is the technique we are using, but other, as I said, other possible options is to act with the IGF-1 and EPO. This has been translated into clinical study. BITROP was the first, done by Helen Hittren in US, and then two international studies. One is the Rainbow. First one was the Rainbow, completed 3 years ago, and with statistical evidence that anti-VEGF seems superior to laser compared to laser for the treatment of severe ROP. And the second one is the Firefly. We don't reach the non-inferiority criteria toward the laser, but the difference is very small. And we are looking for the 5 years data that will come next year. And we can assume that we have a very powerful tool now to treat ROP. You're probably familiar with the results of the results of the Rainbow study. It's important to just this schema, because you understand that 60% of the baby we treat are zone 2, stage 3 plus, and only 30% are related to the zone 1. And in particular, you see that AP-ROP, or the new classification AROP, is only about 13% of the baby that we treat, so it's quite rare. We only treat 3% of the babies without plus, so essentially we treat plus, which is something that we have to consider, because maybe it's probably just waiting for plus is sometimes too late. The results were here, and the superiority not matched by 0.004. This is probably due to the fact that we are very strict in defining the favorable outcome. This is the translation that the Lancet editor asked us to use, and that's why we use the criteria seem superior. Time is important to see this schema, because we understand that anti-VEGF is very fast, allowing regression both for plus, stage 3, and even in the AP-ROP. The additional treatment is important. We know now that this is done by Brian Fleck. It's fantastic work. We treat additional who require the additional treatment. Essentially are the AP-ROP and zone 1 ROP, and they were retreated when they reached the zone 2. So pay attention, because these are at risk for retreatment, and the retreatment rate is about 30% in the Rainbow study, and is less in the other study, in the Firefly. Just to be quick, the results you know already. Important to see that we have less high myopic eye in these babies. The results we have a difficult assessment of the peripheral retina when you only use the indirect ophthalmoscope. And again, we don't see any difference like which pointed out in his study. Firefly is the same study, except the fact that we treat also on monolateral studies, and the Fowler's outcomes are almost the same compared to the laser. And again, the ophthalmic outcome at 2 years seems the same. We have to stress that we didn't have any long-term reactivation. This is important, and we have a very powerful instruments to treat ROP. We have to keep in mind that we have to be aware of the reactivation, but we didn't see any long-term reactivation at least in this study. But we need to remodel our guidelines in terms of either organization of the follow-up and probably also of the criteria that leads to treatment. Briefly about what we can do in the future, the fantastic work that Anand has done with the indirect predictors, indirect non-ophthalmic predictors is very important. We are looking for biomarkers that allow us to understand who's the baby that are at risk for reactivation. And the tear fluid inflammatory factor seems to be very promising in giving us an instrument to understand and to point out the risk of the reactivation. Our study on fluorescein angiogram seems promising, more invasive, of course, but still very, very sensitive based on the fact that we show that it's a Shansen leakage in the fluorescein angiograms done after treatment can be a factor that allow us to understand who's going to progress toward the retreatment. And again, what we have to do in terms of theoretical intervention, we have to try to restore local and temporal gradients of VEGF. That means we have to inject in the right place at the right time. And it is feasible, yes, it is visible. Now we have instruments that allow us to deliver anti-VEGF exactly at the right place. And we are working on that. And the work of hemiartenet on receptors also is very important. Again, we don't know exactly the quantity of VEGF we need to restore the regular angiogenesis, and we can act blocking the VEGF directly, or even acting on VEGF receptors. In particular, if we are able to rescue the VEGF receptor 1, we can be able to restore the normal angiogenesis. And this is what also what Amy did years ago. The gene therapy that reduced the effect of the VEGF receptor 2 seems able to inhibit the pathological angiogenesis and allowing restoring the angiogenesis in the physiological way. And other possible intervention will be all these sites of the angiogenesis process. So a lot of work has to be done. And talking about future, and I hope to see you in Florence in December for the World ROP that we are organizing together with my friends here. Thank you so much, and sorry to be late.
No problem. Thank you so much, and that was very good insight. Which you have any questions? We have a lot of time for discussion because we have just 5 speakers. So, but we can take questions right now if anyone has them from the audience. Yes, please. You can just walk up to the mic.
Yeah, Lepori, can I have a question for you first? Since you have vast experience of using anti-VEGF in the treatment of ROP, and right now the BROP study, Rainbow, the Firefly study all came out. So do you have a preference of anti-VEGF for your clinical practice? And do you think that the different anti-VEGF could result in different angiogenic growth in their retina? Do you think that would affect that, or it's probably the similar fashion?
We started with the Avastin, which was the only one available almost 15 years ago. And then we shift to Lucentis because of the regulatory system in Europe allowed us to use the Lucentis. And right now, since we have the opportunity to choose among three different drugs, we shift to Eylea because of the lower rate of reactivation. And we are all concerned about reactivation. I'm concerned also about the study that you cited, Anand. And we are going back to review all our cases. And I think that there are a lot of confounding factors when you look at this population, because they are very sick, and sometimes the babies that need retreatment are sicker than all the other. So if you have to keep in mind that if you look at this population, the retreatment rate in a very sick population is very high. So when you look at the data, you have to be aware of this difference. Personally, with Lucentis, we had the retreatment rate. We didn't retreat with Avastin. So we published this data because we were monitoring with the babies with fluorescent angiogram. Probably you know all the results we had. In the Lucentis population, the retreatment rate was around 25% of the babies. And we didn't find at the moment, it's just a preliminary observation, any difference between both in the retina and the neurodevelopmental issues of these kids. We are now starting with, we started with Eylea only 2 years ago, so data are not so important, it's not so consistent right now. But yes, we need to find out biomarkers that allow us to understand who will be retreated. But what is important, I think, we reconsider the criteria we treat. We are still treating based on ETROP, which is 05, right? So it's a very old study, it's 20 years old. And since that period, everything has changed in our life, in our way of treatment of babies. And we need new treatment criteria.
Yes, we have a question from the audience.
Hello, good morning. So
Please declare yourself or introduce yourself.
Yes, so my name is Kritishna, and I was just wondering, considering we know VEGF's role beyond the eye, could it be possible that, considering we talked about anti-VEGF injections, so could systemic anti-VEGF exposure lead to epigenetic effects in the future?
We still don't know. We are one of the things that we are investigating at the moment. Yes, we are concerned also about this possibility. Yes.
I think that's the importance of the neurodevelopmental impairment studies that are coming. I was just quoting after he spoke that one meta-analysis says there's a higher chance of NDI with anti-VEGF, but again that is a meta-analysis from 3 decades, so the way the studies were taken and the inclusion criteria is not the same, and predominantly one drug. Yeah, so I think that's definitely an important consideration to look at.
Yes, and definitely there's a likelihood that considering we're using this, there could be a very prominent therapeutic window we can use for both retinal and brain outcomes.
Yeah. We have to consider that we have to reorganize all our system. The follow-up has to be longer than 5 years, and even in the study probably we have to consider that we have to go back and review all the cases that have been treated in the study. But in our clinical practice, we have to organize to be able to follow these kids forever. Alistair Fielder was used to say that they are premature for life, and this is really true.
I remember Mike Treacy used to say that once you give anti-VEGF to an ROP baby, you're converting it into an FEVR. So basically, you're defining avascular retina, and you got to figure out how you're going to deal with it.
Yeah, thank you. The talk was really good. I'm Dr. Swati Senkar. I'm from Australia, and I'm a pediatric ophthalmologist. I wanted to ask you anecdotally. I'm not aware of any studies looking at the 3 anti-VEGF treatments and their sort of rate of reactivation of ROP. But what we found in our institution is we found more reactivation with Lucentis than Avastin. We haven't started using Eylea yet. So have you found the same thing, or do you think Lucentis gives you less reactivation? Because we found the other way. So that was my first
Published
question.
literature exactly mimics what you're saying. Yeah. We recently, the Indian ROP Society published about 10,000 eyes, a collaborative study of many members, and we found exactly that. The subsequent paper will show us exactly the rates, but the least reactivation was with bevacizumab, and Eylea comes in between, and Lucentis has the highest reactivation, and not just the proportion of reactivation, but also earlier reactivation. We found it 3 to 4 weeks after injection, whereas in bevacizumab it was 12 to 16
That's
weeks.
exactly right. Yeah, that's what we found too. The other thing I was interested in your tier.
Just to answer your question, it's important also the data that David Wallace got from the escalation study in US, and is the quantity of the the Avastin we use at the beginning was very high. So if we go lower with lower doses, we find more reactivation. So this is based on those effects of the anti-VEGF, not only by the difference of the molecules.
That's right. Okay. The second question, I was interested in the tear film inflammatory marker. He's pointing to you, so I'm looking at you. When do you take the tear film sample?
Okay.
Sorry, I must have missed your talk. I don't know. I'm sorry.
No.
But yeah, when do you take the tear film?
Our aim is to use it as a predictor. So we take it during the first screening, when the baby doesn't even have ROP.
Okay.
Of course, in a subset, we have also taken it in babies who've had ROP in the very first imaging session. But our idea is not to be able to look at the tear biomarker and see what's correlated with what's happening in the eye. That's not then a predictor.
No.
So we are now able to, we've narrowed it down to 5 biomarkers, and I can share that again after the session.
Thank you.
We had 86 analytes, we've come down to 20, we have 10 now, and now we have 5. And with those 5, a few of them are angiogenic, like ANG2 and VEGF, and 3 of them are inflammatory molecules, RANTES, IL-8, IL-6.
Yep.
And their proportion, along with a few more demographic details, like the gestational age and the postmenstrual age, we're able to predict whether this baby will eventually get disease few weeks down the line. And that's how it's becoming a predictor. But what we have failed to see yet is that this baby, a sicker baby, as he said, are the ones who are going to have worse disease and maybe even worse reactivation. We've not looked at their sickness factors, and we've not looked at their demographics in this model. And that's why we are using artificial intelligence to integrate the two.
So the tear film is, as I understand, tear film is a predictor of whether the baby is going to have ROP.
Correct.
But not for reactivation. So
Correct.
are you following up for reactivation as well? So
That is the hope, but right now
Yeah.
we've not
Okay.
focused on that.
Alright.
That
No,
is-
thank you.
The same is for fluorescein angiogram. We did fluorescein angiogram at 31 weeks.
Yep.
And this is a predictor for evolution, either for the first activation and reactivation. So if you look at, and probably only look at the color fundus, you can be able to predict who's going to reactivate. And this
So
is
for
because the artificial,
sorry.
just to finish, the artificial intelligence is able to show us vessels even better than fluorescein angiograms. And this is very important because in the future, you will not need to inject fluorescein. You only have to pick a good picture of the periphery of the eye. And this is what we are trying to do with Darius and Mosfigi in Jochen Kuhn in Stanford.
So Anand, in the tear samples, actually there is no standardization value for these.
Correct. We don't have normative data, which is why we needed to know assays which we can pick up the molecules. These 86 analytes were done from basic science research, like he presented in his first few slides. But many of them are undetectable, at least with the current modalities we have. So they just get taken away. And then we start correlating it using multiple studies to make sure that they are measured in the right format.
So you just use a baseline, single measurement without.
That's
like
how we started, but now we are doing, we have a follow-up study. The same baby is, the tears are taken every week, every 2 weeks, and then we follow the disease and the biomarkers as well.
Thank you. Thank you.
Professor Lepore, we invite you to join the panel there because please be seated on the dais. We'll continue. We have 2 more talks, and then we have, I think, plenty of time to continue this discussion. I'd like to invite Dr. Supriya Dabir. She's a consultant senior retina surgeon in Chennai, and she's been doing ROP work for more than 2 decades now. She's going to give us this very interesting talk on IVF modulation in ROP.
Good morning, everybody. I'd like to thank the Scientific Committee of APAO and AIOS for letting me present our data on how IVF modulates in ROP. So we know that ROP is a cause for preventable childhood, especially in the third world countries like India with a very high incidence. Mainly the reasons could be the increase in the number of neonatal intensive care units, the higher rates of preterm babies, the increased survival of these smaller babies, but lacking timely intervention in the form of screening, a lack of awareness among the pediatricians and the ophthalmologists, and the lack of access to trained ophthalmologists to do the same. So looking at infertility, according to the WHO, it has become very popular in the 21st century, and the incidence of the primary infertility rates are increasing more in the urban as compared to the rural population. Artificial reproduction techniques are defined as procedures that include in vitro handling of both human oocytes, the sperms or the embryos for the purpose of establishing a pregnancy. And the main techniques that are a part of ART are basically IVF, which is in vitro fertilization, IUI, which is intrauterine insemination, GIFT, which is the gamete intrafallopian transfer, and the ICSI, which is the intracytoplasmic sperm injection. Studies have proved that the use of IVF may lead to premature birth, and this could be because of the use of the autologous or the thawed oocyte, superovulated hormonal regimens, which could lead to disturbed endometrial maturation, increase in the maternal age, the different types of infertility, chromosomal anomalies, the epigenetic disorders, which causes abnormal methylation, cryopreservation. So these babies, apart from ROP, have an increased incidence in ocular comorbidities like the Coats disease, congenital cataract, glaucoma, colobomas, microphthalmus, retinoblastoma, etc. So the aim of our study was to basically establish whether IVF is associated with an increase in the incidence of ROP in these preterm babies at a tertiary eye center in south of India. It was a retrospective comparative study where the preterm babies were screened under the ROP, which is a rotary-assisted retinopathy of prematurity project, a multi-centric outreach project. We collected data between April 2019 to 21 of August. We looked at the babies who were screened were less than 34 weeks of gestational age and a birth weight of less than 2,000. They were screened 4 weeks postnatal age. When they were less than 28 or equal to 28 weeks of gestational age and the birth weight was less than 1,200 grams, we screened them much earlier. And if they were also screened if the babies had additional risk factors. We did an indirect ophthalmoscope, and the documentation was done using the Trinetra Neo camera from Forus. This is the project van where the camera is carried. These are the cards. Each baby is screened. Hospital is screened on a particular day of the week, and they're all given these blue cards like an immunization card where all the risk factors are noted here and the demographics are noted, and at each visit the findings are noted here. This is the sheet which is left at the center with the at the NICU, so that the neonatologist is also kept in the loop of things. This is our technician doing the photography. Intravitreal injections were given where needed. We used both bevacizumab as well as Lucentis and Razumab in the form of ranibizumab. Pre-injection, post-injection, these are the different images showing regression of the regression of the ridge, regression of the plus disease. And we mostly do a combination treatment also, where laser is done wherever the avascularization stops. On follow-up, these are the images showing the pre-laser and the post-laser data. So we had a total of spontaneous conception babies were 373, a total of 444 babies, where 373 were of spontaneous conception, and IVF babies were 71. We found significantly more twins and triplets in the IVF group. when we looked at the comparison of the risk factors between the different groups, we found that the neonatal risk factors were more in the spontaneously conceived, basically the respiratory distress, oxygen supplementation, the use of surfactant, transient tachypnea, and IUGR was seen more in the babies with who were spontaneously conceived. 99, that is about 22% of these babies had ROP, but we didn't see a statistically significant difference in the incidence of ROP between the two groups. However, there was an increase in the presence of ROP among the twins and the triplets as compared to the singletons. In the spontaneously conceived group, 2 babies had stage 4 ROP and another 2 had AROP, while none of the babies in the IVF group had ROP more than stage 3. Though the incidence of the higher stages of ROP, that is stage 3, 4 and AROP, were more in the normal conception group, the difference was not really statistically significant. So to conclude, there was no significant difference in the mean birth weight, gestational age of the between the two groups. There was a significant increase in ROP in babies of multiple pregnancies rather than singletons. And if you look at the incidence of ROP or the stages of ROP, it was almost similar in both the groups, but more severe ROP like AROP and more than stage 3 were found in the normal conception group, though this wasn't a significant difference. This could probably be because of the increased quality of preterm care and awareness of the risk factors, including oxygen supplementation among the neonatologists, and this could have contributed to the comparable incidence of ROP in our studies. There's, however, a meta-analysis done by Gao and group. They looked at about 219 studies and then zeroed in after they removed some of the papers because of references not being intact, or they were just basic researchers, conference abstracts. There were some who had, there were some who were duplicated, insufficient material was recorded, and eventually they found 15 studies that they looked at, and there was significant association between the maternal ART use and ROP occurrence was seen in singletons. However, in multiples, there was no significant association. The association between ART and stage 1 ROP was just at statistical border. Stage 2 didn't show any association, and stage 3 did show a significant result between association between ART and stage 3 ROP. Now, ART could show a significant association with ROP in the singleton group, basically indicating the notion that multiple births have a higher risk of ROP. This was attributed to the difference in the lower gestational age and the body weight of the singletons. However, ours was comparable gestational age and the body weight between the various babies of the two groups, the control as well as the IVF babies. Following IVF, Watson Adams reported a higher incidence of stage 3 ROP in the babies conceived by IVF. Chinovofa, and in their study, they show that ART may be a single independent risk factor, but in these babies, it could be a confounding factor because they have so many multiple risk factors, and hence it loses its significance about its contribution to ROP by indirectly influencing prematurity and the lower birth weight. Barker et al. Didn't show any significant difference either. This was IVF, but when you look at the rest of ART and its association, that is the other forms, GIFT and IUI, the association between that and ROP was not really significant. This could be basically because IVF, most of the that forms the about 60% of ART, leaving the others as a very small percentage of the group, and this could bring a bias to the results. And also IVF requires many in vitro procedures, so these gametes of fused zygotes could have got harmed along the way. To summarize, with increasing adoption of ART and pro-prognosis of ROP, it is necessary to try and discover a relationship between these two aspects. It is worth noting that initially they would implant a lot more embryos, but now the number of embryos that are implanted are much lesser. So even singletons need to, even though it is a singleton delivery, the couples and the doctors need to take a risk of ROP occurrence into these babies, and a greater vigilance experience is required for screening these precious babies. However, maternal factors, the complexity of the ART treatment, different screening standards, they make specification of these individual factors really challenging. There are racial and genetic factors in the implementation, and there's not much data from the Indian subcontinent, and our study was one of the first to try and analyze this association. More randomized studies are required to find this association with the incidence of ROP. Thank you very much.
Thank you, Dr. Supriya. I think that's a very interesting association you brought out. We had published a few years ago multiple gestation in ROP, and we had 13 triplets. It was a curious association. 13 was too less to do a statistical analysis, but we found that the third baby out of the triplets never had ROP. Only the first two had some level, stage 1 or stage 2. And then we found that out of those 13, 10 out of those 13 were females, and female is a relatively protective factor because male is a risk factor for ROP, but curious association. So while doing that study, we had contacted fertility specialists. And what your study brings out, the fact that multiple gestations may not have the worst disease. Two factors that they actually do. One is, since it's multiple gestation, almost invariably it would be a C-section and not a normal vaginal delivery. And it's also a planned C-section. And so they know they would date that and look for lung maturity. And almost in 100% of cases, they will give the antenatal steroid, the dexamethasone for the lung maturation. And they would complete all 4 courses. Usually it's 2, and I think they go up to 4. So this is probably one of the reasons why they are protected, because it's planned. They wait for as long as they can hold on, unless there are uterine or cervical factors, and then they ensure that the antenatal steroids is given. So maybe you can go back to your data and see whether the antenatal steroids were missed out in the singleton pregnancies, and that's why they had the worst disease.
Right, yeah.
Dr. Supriya?
I think that was a limitation because of our retrospective analysis,
Correct.
but we can look at it prospectively for sure.
Thanks very much for your wonderful study, and
Thank you.
your results are very interesting. And one of the factors that could compound the result of analysis is like twin transfusion syndrome. So usually, if you have twins, one of them got more blood, and one of them is sicker than the other one. So have you considered this factor into your analysis? If in the IVF they have more twins than the spontaneous delivery?
The
groups?
IVF did have more twins, yes.
But do you check that whether one of them is worse than the other one? Or
We didn't analyze between them. Yeah, the subgroup analysis is not something we looked at, but yeah. Thank you.
I wonder if there is any way. I'm sorry. Thank you for the presentation.
Thank you.
I wonder if there is any way to predict a premature birth in this population, because they are, of course, a risk, and predicting maybe could be helpful to organize and to do everything in the right place. So
Yeah,
prediction is possible in a premature birth in this population?
I think if we work along with our obstetricians and then try and see which are at-risk pregnancies and follow them up, that would probably help us.
Okay, just follow up. You don't have any marker or any
No,
biomarker to use?
Yes, not yet, yeah.
Except for the fact that it's a planned C-section. So in some respect, they wait for about 34, 35. They'd ideally like to take it to 38 weeks, but at least they wait for 35, 36 before they...
There are some centers of IVF though that, they try and deliver the babies much earlier to have a higher success rate before the complications actually set in. So they do deliver these babies. We have one center in Chennai which actually delivers these babies between 32 and 34 weeks. And they have a very high success rate of, live births. So that kind of does complicate the data and skews it.
What they are trying to organize in Italy, at least some region have already done this, is to move the mother in a safe location. Means that right near the hospital where the delivery will be, And this helps a lot, because if they have a premature birth in a place that is far from the hospital, this could be another important complication. So in terms of logistics, at least since this is a very high-risk population, probably move the mother toward the hospital during the pregnancy will be very helpful in preventing the complication related to delivery. Yes. But I was thinking about some inflammatory marker that can allow us to understand which mother is more at risk to delivery prematurely compared to the other ones. Yeah. And maybe even the fundus photo can help us to, because by the fundus examination you are able to find out some inflammatory condition of the mother, and so probably this could be another way to explore the risk of premature birth.
Yeah. Some good food for thought. Yeah.
Yes, that's very interesting. Thank you.
Thank you, Dr. Supriya. Please join us on the panel. It's now my privilege to invite our president of the SAO, also multiple hats that he wears. He's the president of the Indian ROP Society and the World ROP Council and the Asia Pacific Pediatric Vitreoretinal Society, but today he will fulfill his role as the SAO president.
Anand.
Dr. Azad.
We are going to, we had a good presentation, and I'm going to tell you about the ROP screening program, considering India and considering other countries where there's a large population. And we have to reach to the most rural area. And if we talk about that, the technology comes to our help. Yesterday, we had a session on the technology and education, and where we discussed about the availability of different types of the advancement in the technology. Online platforms are there. The telemedicine approach is there. That's all this we'll be talking about. And the other reason why I chose this topic was that now I'm attached to a very big eye hospital. It's a high volume surgical hospital where more than 1 lakh surgery is done every year, and 700 standalone eye beds, so you can understand. And then they have satellite hospital. We have around 20 satellite hospital, and that is in the state of Bihar. And Bihar, is a state, although recently there have been a lot of developments, but then still there are far-reaching areas where the services are required. इसको चेंज करो यार, चेंज नहीं हो रहा. नहीं, I can change from here? Okay. So, there are various estimates are there. 10% of the global estimate, India accounts alone for 10% of the global estimate. And children developing severe ROP, 5,000 developing severe ROP, and 2,900 surviving with visual impairment. These are figures, this figure will vary, and because time to time. And the economic burden of blindness and visual impairment due to ROP is estimated to be a net loss of 845 billion Indian rupees in gross national income. So it's a huge amount of money, which is involved there. And what should be the strategy for scaling ROP screening program? And as we often talk about the blindness program and reaching to the unreached population, that there are 3 factors which are very important. One is the accessibility, the other one is the affordability, and of course, if we want to make it accessible and affordable, we have to sustain it, because sustenance involves not only the methodology and the manpower, but also involves a lot of finances. And in India, the ROP program, screening program, is linked with National Program for Control of Blindness and visual impairment. And now it is linked to it is called RBSK, and it is in Hindi, Rashtriya Bal Suraksha Karyakram. Means basically it is, the children health, protection or prevent healthy program. That is what is it. And in NPCB, when I was advisor to Government of India, that time I think it was 2011. Anand? 2011, we put it in the ROP, in the National Program for Control of Blindness. And we had a national task force on retinopathy of prematurity. You can think of India and having a national task force there. It was a big thing there. And we continued with this program. And we developed the guidelines and other literature and all that. And I mean, the program is still going on, but this program is going on with the Rashtriya Bal Suraksha Karyakram. Now, what are the strategies for screening if we want to do it in low resource setting? First thing is the capacity building. So you need to have, people who can, diagnose or who can detect or who can even, take the pictures as it is done in telemedicine. And we need to integrate it with the neonatal care services. And I like to tell you here that we had a lot of these workshops. I think in year 1999, 2000, we had a workshop with the Ministry of Health and the WHO, and we had the concept of paired workshop, and where there was integration of neonatal care services. We invited the neonatologist, and we had the ophthalmologist together. And in fact, I say that the ops gynae people should also be there. It should be, a joint approach. Because I say that this premature babies, they come from the gynae or ops department to the neonatologist, and from neonatologist, it is a gift to ophthalmologist. So we have to handle the gift very well. And then, of course, most important thing is awareness program. As I told you, we started awareness program 1999 with Government of India. Then we had a lot of these site saver workshop, almost more than 20 workshop. And then with the workshop with the Orbis International and many other organizations, we had workshop with the government in different states. India is a big country and there are 25 states. And some union territories are there. So a lot of awareness is required. And then we need to have the telemedicine, because to reach the far-flung areas, that is very important. At the same time, it has to be cost-effective and, of course, sustainable. And very important is the monitoring and evaluation. More often it happens that the program is there and the program is launched. And after that, nobody looks to that, what happened, and also the evaluation. So talking about the human resource strengthening, we need to have, training for the neonatal nurses, to the pediatricians, general ophthalmologists. And in fact, we did a very interesting study where we trained the nurses, neonatal nurses, and the residents, and I think these two people, and we trained them for 3 weeks about, ROP, both the theoretical and the clinical part, and we, put them for the examination to detect ROP. And we found that the acceptability and the diagnosability was almost to the extent of 80, 85, 90%. So if you have shortage of the experts, ROP experts, we can definitely induct the nurses, the pediatricians, and the general ophthalmologists. I have not mentioned here the name of the study, but it was in Indian Journal of Ophthalmology. And then awareness regarding risk factors, although she has presented about the multiple gestations and the various risk factors, more or less any study that has been done, the more important risk factor remains two, the gestational age and the birth weight. And the other risk factors here, sepsis is very important. We have, respiratory distress syndrome, stay in the NICU, blood transfusion. All these factors will remain same, maybe a little bit this side or that side. So, but more or less, these are the risk factors. And the capacity building definitely is very important. And as we talked about the integration with the neonatal care services, which is very important. And here there is a point. The point is when we do the screening, we need to do the screening in neonatology department because the child is, the infant is very, in a critical stage. And it's very difficult for the transportation of the baby from there onto the this eye department, and in that way, it's better to do the, the screening there. I think most of us are doing screening in the neonatology department. In fact, many people, they keep the laser also there in the neonatology department, and when the need arises, then you can do the laser itself there. And that is very, comfortable, and it's very easy to do that. This is very important, community awareness and parental engagement. We have time, no? Yes, we have many time, a lot of time. So this is very important, awareness and the parental engagement. And in this, I'll tell you that those who are engaged in ROP management, the eye from outside looks normal. And when the eye from outside looks normal, the parent do not have the idea what is happening inside the eye. And then, when they come to you, they come with lot of hopes. We have had babies, who were in stage 5, and they were not screened earlier. They come to us, and then when we see and they come with lot of hopes. They think that everything will be all right. I have come to YGU, I have come to Anand, I have to come to Supriya, and I have to come to Domenico, and because they are, the experts, everything will be all right. So parental awareness is very important, and that's why the awareness program and the workshops are there. We have, as I told you, we had several workshops. Even now, despite, I think from almost now, how many years? 25 years of awareness program in India by each one of us. Despite that, we are getting stage 5 cases. So this is very important, and make parents aware about the risk factors, which are very important. And this is something very important. And here I would like to point to you another thing, that of course the pediatric fundus camera is very costly, but then it is a big tool for making the parents aware. When you show them on the screen that look, this is like this is what is happening inside the eye, then they become aware, and then they are more concerned. And then the telemedicine, using the technology to reach far-flung areas. And in this, telemedicine has come to our rescue. And there are various types of these telemedicine approach. And it may be mobile-based apps, or maybe regional screening hubs, or there may be now a lot of these AI-assisted screening tools to reduce the workload of the experts. And we need to have, especially, I think most of the countries, not only in India, other countries are also finances are a big issue when these babies come to you. And laser therapy is less expensive, requires expensive equipment, but when it delivers delivered to the babies, it is less expensive. And in India, I think a lot of these Indian companies, they are making the laser machine. And the local laser machines are as good as the machines which are from abroad. And they are less expensive, and therefore you can do the treatment at lesser cost to the patient. And again, coming on to anti-VEGF injection, which is become a very ubiquitous mode of treatment. And sometimes it is being used indiscriminately also, which is unfortunate. And we need to keep a check on that. But although it is difficult, but we need to have some kind of mechanism to control and regulate that. And as long as this anti-VEGF is concerned, and we talk of the cost, definitely Avastin comes to our rescue. And the screen and treat model is another way for the immediate intervention in infants for those who are at high risk. And again, as I told you, the finances are very important, and we need to have an advocacy and talk to the government. We have Indian ROP Society here, and which is a very strong group now. And earlier we started in 2016 with how many members we had? I think 34, 35 members. Now we have almost more than 250 or maybe around 300 members we have. And we are, because if you have a group in the country, you can advocate the requirements, and you can force the government to make a policy. And many places, the government is itself, taking up this program. As in India, there is a national task force. I believe there is in Thailand also, there is some government has taken up this issue. I was in Thailand, I think 5-6 years back. And in Philippines, there is a group, ROP group, in Waichi place, Taiwan also, I think. There also, like that, those groups are there. Basically, these groups are to, form the policy, form the guidelines, give the support in terms of, screening, and in terms of early detection, in terms of, suggesting the correct mode of treatment. And of course, there are a lot of agencies, which can support you with the funding. And in India, there are some foundations are there, and also the corporate houses are there. So corporate houses, there is a provision for CSR. So from CSR, if you make a presentation, then you talk to them, they'll definitely help you and give you a financial support. And as I told you, monitoring and evaluation is very important for any program to be successful. We need to monitor it constantly. Regular audit should be there, and we should have a cost-effective models, research on cost-effective models continuously, so that we can make it more, the program more effective and more far-reaching. And when we talk of the telemedicine models, Arvind and LV Prasad, definitely they have this model, but I have a person here who is the person who is responsible for KidROP, Karnataka Internet Assisted Diagnosis of Retinopathy of Prematurity. And this is a wonderful work, and the KidROP has provided free screening and treatment for ROP for all government hospitals in the state of Karnataka since 2007. It's all because of this guy who is sitting here, and that is the reason he is with me. I'm with him, the other way around. So the key features of KidROP is, of course, he is the right person to speak on that, but then he has allowed me to say a few words about that. The telemedicine-based ROP screening program is there, where he uses wide field digital imaging Earlier, he used to use RedCam. Of course, most of us were using RedCam. But now, because of the Indian manufacturer is there, and he's making the pediatric fundus camera, this is called as Neo. And Neo is as good as RedCam. I'm not advocating for any company, but for the sake of cost, I am just saying that it is as good as RedCam. And this is very good tool for screening of premature infants in rural and underserved areas. And images, the process is that images are captured by trained non-ophthalmologist, by technician. And then it is transmitted to the experts for diagnosis, like Anand and few of his own colleagues. And then, action is taken. And then local healthcare providers like nurses are trained to capture images and provide preliminary evaluation. And of course, the diagnosis is and guidance is given remotely for these babies who are required to go for treatment or maybe for follow-ups, whatever it is there. And he has been able to, collaborate with the National Health Mission in his state, and he provides free treatment and screening and treatment to infants in government hospitals. So most important is early detection and the timely treatment. And of course, the window of treatment is very small. If you detect that some baby, some infant needs treatment, then the window of treatment is, or window of waiting is only 72 hours. So within that period, you have to give the treatment. And this is the impact. The reach is up to 177 neonatal units across Karnataka and 9 other states also. This program is running. And there is a significantly reduction in the blindness because of retinopathy of prematurity. And inspired by this model, the other states, Maharashtra, Tamil Nadu, and Kerala, they have been able to adopt the similar models. And now they are, using AI and automation for better image interpretation. So I think, so in summary, 3A strategies: accessibility, affordability, and adaptability. We have to have good screening tools, capacity building, and low-cost equipment, and integration with neonatal care is very important because without them, it will be incomplete. And community participation and counseling is, of course, the most crux of the management of retinopathy of prematurity. And telemedicine approach is something which is very much required for a country like ours and many other countries where the the healthcare is not being able to reach up to the rural areas. So thank you very much, and thanks to everybody.
Thank you, sir. We have a few minutes before we close the session. If there are any final questions from the audience, please walk up to the mic and ask any of the speakers.
Anand, for your tear film study, do you think the finding you found that associated with those marker information or neovascularization marker, those could go back in turn affect the ROP status in the eye, or they are probably the end result of the ROP? Could it be the cause, or could it be the end result?
Since we are detecting some of these biomarkers before the disease is even formed, it may not be a consequence of the disease. We think it's physiology going wrong. For example, if a baby has low VEGF to begin with, that's when the vascularization should proceed. The babies who had the lowest VEGF in the first screening had the highest risk of developing disease later. And that's because vascularization didn't happen at the right time. So it's physiology going wrong. But once the pathology has set in, then the biomarkers profile completely changes. And at that time, it's probably an expression of what disease is going on at the back. But also, and we know this because we've also looked at the biomarkers changing with respect to therapy, both laser and anti-VEGF. And as expected, some of those markers will change. So it's mostly an expression of what's going on when pathology sets in. But before pathology sets in, it's just physiology in progress.
See.
No, we're not doing serum, at least we're not doing it for babies. There is a VAST study going on at our institute, but for adults, and that's vitreous aqueous serum tears. But that's for correlating in adult retinal pathology, but we're not taking blood samples.
I have question for Professor Azar. First is like in Taiwan, actually they have a system. If your NICU have a good screening, they give you a reward, give you a more reimbursement incentives. If you don't do it well, there's a punishment. Your NICU will be downgraded and get less money from the government. So the system turned out to be working very well. No one want to be punished. Have that been implemented here? And the second thing is the telescreening. Is telescreening really cheaper than the on-site screening? Is when you do the telescreening per screening, would you get the same amount of reimbursement from government or a little bit less?
Right now, punitive action and rewarding action, great idea. We've not yet, we can advocate it to our government. Costing, yes, our KidROP model was studied in 2010 by the Indian Institute of Management, which is a top B school here. And they had worked out that the average costs would be much lesser if you do a telemedicine approach. However, are you getting reimbursed? No. Right now, ROP screening is not reimbursed at any level by Government of India. No, not for screening. Only treatment is reimbursed, and that is something that we are going to advocate very strongly to the government.
See, what you said is, if you see the difference between telemedicine, cost of telemedicine screening and the on-site screening, like, the major roadblock is the cost is there, but capacity building, the experts. You don't have enough experts to reach the far-flung areas. So therefore, we have this approach, telemedicine approach. In my opinion, if you ask me, it will be much cheaper if an expert goes, all that he has to buy is an indirect ophthalmoscope. He goes with the indirect ophthalmoscope and he does the on-site screening, and that is the best way. That's what we used to do earlier also. But now the problem is that to reach those places, number one. Number two, the lack of the expertise. Not many people are there. And therefore, if not many people are there, some people who are not trained, they are doing it, and ultimately landing up with stage 5 ROP. So basically, that is the problem, The problem is that not only about the finances, but the problem of reaching the unreached people. So that is very important, right? And about the incentive, incentive is something very good, but maybe it may be good for a smaller institute or a smaller population. But for a country like ours, it will be very difficult. And more so, we have a democracy here. I don't say you don't have, but here, is a different kind of democracy.
In the interest of time, we've now completed the session. Thank you very much for coming here on a very early morning after the gala dinner. I just invite the faculty for a photograph. That's a requirement here. Thank you.